Good afternoon. So today I'm going to take the topic on aminoglycosides. So rather than looking into the board, what do you know about aminoglycosides? Like anything what you know, you can just tell. Okay. And
Concentration dependent.
okay. Anything else from this side? Anything? Okay. So basically, the discovery of aminoglycosides was for a purpose. It's not like penicillin, like it was just random discover. So this was basically discovered for the treatment of TB and also other infections, and basically it works against gram-negative bacteria. So basically, there are two groups. One is natural and one is semi-synthetic, and there are common. So these are the common drugs. So in some synthetic aminoglycosides, there is streptomycin, gentamicin, kanamycin, tobramycin, and amikacin. And in topical, it is neomycin. Okay, there are other drugs also, but that is not that common. So this is the main thing. Now we have some common properties which we see. So this also comes for as a common property. So it works basically mostly against gram negative bacteria. So it is not orally observed. So basically we will see in IV injections. So and it does not penetrate through the brain or CSF. So then more active on alkaline pH. It's 20 it's not in alkaline basis. It's only on no acidic. It's only in alkaline basis. And toxicity, there are many toxicity we will see: ototoxicity, we can see nephrotoxicity, neuromuscular blockage. We will come later. So there are other properties also. So these are the main. Apart from that, there are relatively narrow margin of safety. Then and all used for sulfate salts, highly water soluble solutions, are stable for months. So then we come to the mechanism of action. So these are the two main points. That is your transport of aminoglycosides through the bacterial cell wall and cytoplasmic membrane, and binding of ribosome, resulting in the inhibition of protein synthesis. So basically, transport of aminoglycoside is into the bacterial cell. So basically the outer coating, so of the gram negative bacteria. So the drug passes through the porous channels. So when it enters, so basically the bacteria becomes sensitive, and there can be cell death, as well as there is protein leakage. So penetration, basically the thing is, penetration is depend upon polarized membrane and oxygen dependent active processes. So basically we have this these processes are inactive under anaerobic condition. Why? Do you know why? Anaerobic condition? Because of oxygen. If there is no oxygen, so it won't support. So because of that. So penetration are 20 times more active in alkaline than in acidic medium. As I already told, this was in the common properties. So streptomycin binding to 30s ribosomes, but other aminoglycosides bind to additional sites of 50s units, as well as 30s 50s interface. So only one ribosome is attached to each strand of mRNA. So with this we have mechanism of resistance also, which I have not mentioned. So first we will say, so the T half-life is 2 to 4 hours, and basically it is said that aminoglycosides, the dosing should not be divided. If it is given in one single dose, it's better, because if you will have, then it is less toxic, nephrotoxic. If you are going to divide the dose, it can be toxic. So because for that only, and basically used for infections, UTI, TB, and in fact respiratory tract infections. So mechanism of resistance. So I will just read. I have not mentioned it here. So acquisition of cell membrane bound inactive enzyme phosphate Uh, the conjugated aminoglycosides do not bind to the targeted ribosome and are incapable of changing active transport like unaltered drug. Other 2 points are mutation is decrease the affinity of ribosomal protein that normally bind to the aminoglycosides. So decrease the efficacy of aminoglycoside transporting mechanism. Either the pores in the outer coated because less permeable or active transport is interfered. So this is not frequently encountered in the clinical setting. Now we come to toxicity, which is very important. So in toxicity, there's ototoxicity, and that can also be categorized. Then we have nephrotoxicity and neuromuscular blockage. So ototoxicity is basically because of basically you precisely see in the drugs and duration of the drug and the treatment ADRs of it. And so ototoxicity is greater when plasma concentration of the drug is persistently high above the threshold value. So like example I can give, gentamicin dose should be measured through the plasma drug concentration. Aminoglycosides like eardrops can also cause ototoxicity because the patient with perforated eardrums, it is contraindicated in them. Now we will come to the cochlear damage. So basically it starts basically from the hear loss, and it can also lead to deafness, and the deafness, it can be permanent. So basically this is seen in the older aged geriatric patients. And then is your vascular damage. You can see nausea and vomiting, apexia, vertigo, dizziness, headache, all these things can be seen here. So basically it's not like only in aged patient, it can happen in any patients. Then is your nephrotoxicity. So it is basically manifest as tubular damage resulting in loss of urine concentrating power. Like you will see low GFR, nitrogen retention, albuminuria. So aminoglycosides attain high concentration in renal cortex. And toxicity is related to the total amount of drug that the patient has received, total drug the patient has received. So basically the drugs, if the patient is having some renal problem, kidney problem, so it's better to discontinue the drug because it is reversible in case of nephrotoxicity. Example, streptomycin and tobramycin is less nephrotoxic than the other aminoglycosides. Then is your neuromuscular blockage. All aminoglycosides that reduce acetylcholine release from the motor nerve ending. The interference with mobilization of central located synaptic vessel of fuse with the terminal membrane, as well as decrease the sensitivity of the muscle end plate. So this much is there. Now we come to precautions and interactions. So basically it should not be given during pregnancy because it can cause fetal toxicity. Then caution also there. Caution is there if it is used above the age of 60 years. So there are some guidelines if it is used. Then caution in the use of muscle relaxant, and do not mix aminoglycoside with any other drug, like with same syringe or same like infused bottles. So this comes in under this. Then is your use and dosing. So basically use, it is for infection, then TB. Basically it was taken out for TB and infection only. It was discovered. So basically there is a dose. So gentamicin and tobramycin, it is 3 to 5 mg per kg per day, and streptomycin, kanamycin and amikacin is 7.5 to 15 mg per kg per day. So amikacin we can basically see, we can see widely it's used. Here also it is mentioned that single dose should be given because of less nephrotoxicity. So So not recommended is gentamicin combined with beta-lactam antibiotics for obtaining sidal effects. So it is in bacterial endocarditis. So gentamicin is commonly used because it is cheap and very easily available, and it is used for acute infections. So against basically gram-negative bacilli like E. coli, etc. Okay, and it is very limited use in gram-positive bacteria. So then come to streptomycin, that is the oldest one, and it is used for treatment of TB, and other uses like streptomycin is also used in case of plague. It takes 7 to 12 days. So subcutaneous bacterial endocarditis. Then is your tobramycin. It is most ideal to gentamicin, and it is used as an alternative for gentamicin. So ototoxicity and nephrotoxicity is probably less compared to gentamicin. So dose I've already mentioned there. Then is your kanamycin, second systematically used as aminoglycosides after streptomycin. Because of toxicity and narrow spectrum of activity, it has been largely replaced by other aminoglycosides. It is occasionally used as second-line treatment for the resistant of TB. So there also TB, the dose actually is 0.5. It is given through IM and BD, and dose is 15 mg per kg per day. Then is amikacin. It is the wide spectrum of active high dose needed. The range of this condition in which amikacin can be used is same as gentamicin. It is used specifically for hospital acquired gram-negative infections, and they can have more hearing loss, and disturbances occurs in the toxicity. So this is amikacin especially used in case of UTI, and dose can be divided from 1 to 3 doses. Then is your neomycin, that is the wide spectrum antibiotic, and it comes under topical aminoglycosides, and that also is used against gram-negative bacilli, and in few cases gram-positive, and it is highly toxic. So this can be very toxic in case of internal ear and kidney, basically internal. So oral and topical administration dose are not is not given, cause it can cause symptomatic toxicity, and basically this is used in case of wounds, applying in wounds, burns, ulcers, external, never in internal, and conjunctivitis. So adverse drug reaction, it can cause rashes. So there is a note. So neomycin containing antidiarrheal formulation are banned in India. So accumulation of drug in this patient can cause kidney and other ototoxicity. And neomycin is contraindicated with the renal function impairment. So thank you.